right, well, good morning, everyone, and welcome to this morning Grand Rounds. It is my great pleasure to introduce Dr. Sara, who is originally from Birmingham. He did his training in medicine in Birmingham and then moved over to the United States, was at the Mayo Clinic for forever. For many years, did his research, internal medicine, cardiology, interventional cardiology, and actually he was one of the pioneers in this field of voice biomarkers that you're going to be hearing in a few minutes. It's very exciting. It's a little different than the average cardiology talk, but I think you'll find it very refreshing and very mentally stimulating as well. He has published almost 80 papers. He's been extremely productive. We've been delighted to have him work with us all this year in intervention, where he's doing a phenomenal job. And today, he's going to talk about the novel speech and voice biomarkers for the remote detection of cardiovascular disease. On a side note, he's actually been the force behind having the VoiceB, a new protocol that is being deployed right now, got the grant from Alina, that is going to help fight the burnout and make everyone excited to work. Thanks so much. Thanks so much, Jas.
Good morning, everyone. It's a great pleasure to be presenting before you all today. And thank you very much, Dr. Biomarkers, for the very kind introduction. So I'll be talking about a very interesting subject today. The title of my talk is Novel Speech and Voice Biomarkers for the Remote Detection of Cardiovascular Disease. I have no disclosures, and these are today's learning objectives: to discuss potential mechanisms that may explain the association between voice biomarkers and disease, to describe the process of developing a voice biomarker, to describe evidence for the association between voice biomarkers and various disease states, and to discuss important future considerations in this area of research. So I'll start with some background. The use of telemedicine has increased over recent years. This, together with the COVID-19 pandemic, provided a strong impetus for healthcare providers to consider alternative ways of delivering healthcare. And so there's been a significant shift from in-person care to non-face-to-face visits. In the graph shown here, we see the proportion of primary care and behavioral health patient visits between February 2019 and August 2020 in a healthcare system in California. And it shows the decline in in-person visits, shown in orange, and a corresponding increase in audio and video visits, shown in green and gray, across both domains. And so there's a growing demand for providing healthcare remotely. So where does voice and speech analysis fit in? Voice and speech analysis is an emerging, non-invasive digital technology that looks at spoken language and utterances to provide information about health status, which, when coupled with artificial intelligence, allows us to generate digital biomarkers that could provide a solution to the growing demand for telemedicine. So why might it be helpful? Well, voice signals could mean anything from a simple sound like a sigh, or the natural language that we produce during a conversation. And these activities require the coordination of a variety of cognitive and motor processes. And so it makes sense that voice signals could provide a snapshot of an individual's cognition, tissue integrity, and neuromuscular functioning at a particular point in time that might be relevant to a number of disease states. Also, the collection of data for voice analysis is simple and engaging for patients. It's relatively cheap and convenient, requiring just a microphone, a quiet place, and a device to capture samples. And from the perspective of a biological biomarker, it allows us to perform repeated and frequent testing, which we know reduces measurement bias and allows us to collect data across time. So this method could permit screening for disease, monitoring of progression of disease, monitoring of treatment response, and could even provide a useful surrogate biomarker that we may be able to use in clinical research. This slide outlines our current understanding of possible mechanisms for the association between voice biomarkers and disease. Voice signals are the expression of our thoughts and ideas through the transformation of airflow into sound patterns. This process requires the cooperative efforts of three different systems. There's the lungs, which provide the airflow, the larynx, which contain the vocal folds, whose vibrations create sound, and then the articulators and the vocal tract, which are all the structures above the vocal folds that further shape these sounds. And so it follows that abnormalities to the structure or function of any of these components could give rise to characteristic voice features that we may be able to detect. Now, these abnormalities could arise from primary disease, or they could arise secondarily from underlying neurological, vascular, or other systemic processes. From a neuromotor perspective, we know that cranial and spinal nerves participate in speech control, and so disease or injury to any of these structures could result in changes in voice. Studies have also shown that diseases like diabetes and hypothyroidism are associated with specific vocal abnormalities, implicating the potential role of the endocrine system, while other studies have shown a link with immune-mediated diseases like rheumatoid arthritis and SLE, implicating the potential involvement of the immune system. And then obviously most relevant to us is cardiovascular disease, which could modify voice through a number of different systemic processes. First, atherosclerotic vascular disease might lead to hypoperfusion of organs of phonation, which in turn could lead to structural changes like atrophy and calcification that could lead to changes in voice characteristics. Second, atherosclerosis is a systemic inflammatory process, and immunological processes may affect organs of phonation in ways that we can detect through the voice. And lastly, cardiovascular disease could play a role in modifying voice through its close relationship with the autonomic nervous system. We know the vagus nerve innervates the heart, and that its activity is tightly coupled with heart rate control and heart rate variability. And so an assessment of voice signals may provide a snapshot of cardiovascular health by, in a sense, interrogating the autonomic nervous system. And lastly, voice signals may also provide an objective assessment of our psychosocial states. We know, for example, that this link underpins some of the unique linguistic patterns that we see in patients with depression and other psychiatric illnesses. Now, for this field to mature, we're obviously going to need more studies looking at causal mechanisms, but hopefully this provides a useful framework for us to think through. So let's consider some of the characteristics that makes a voice biomarker useful for us. This is the fact that they can be obtained remotely, the fact that they are non-invasive and non-intrusive, the fact that they can be acquired in a short period of time, that they're independent of language and geographic location, that they're independent of age and specific to diseases, that they can be combined with other digital technologies, that they allow for the protection of patient information, that they can be integrated into established clinical protocols, and that they can be integrated into the electronic medical record. So now we'll move on to classifying voice biomarkers. Currently, there's no existing practical framework that we can use to characterize voice biomarkers, and so here's an attempt at a possible framework. Voice biomarkers can be derived from verbal sounds, speech, that include words and sentences, or they can be obtained from vocal sounds, which are sustained sounds that have linguistic meaning, so things like vowels, consonants, and syllables. Or they can be obtained from nonverbal sounds, which are sounds that have no linguistic meaning. So these are things like coughing and wheezing and so forth. And we can use active tasks or passive tasks to obtain these samples. Active recordings require engaging participants in specifically outlined tasks, whereas passive recordings involve free and spontaneous speech and utterances. So on this basis, we propose a novel 4-position classification system for the development of voice biomarkers. Position 1 refers to the source of vocalization used, with S denoting speech, V being vocal, N denoting nonverbal, and D all of the above. Position 2 refers to the assessment strategy, A denoting active tasks, P passive tasks, and D both. Position 3 looks at the analysis strategy, A looking at acoustic features, L looking at linguistic features, and D being both. And in a few moments, I'll talk about what those terms mean. And position 4 refers to recordings that are performed in person, denoted by I, and R represents recordings performed remotely. Now, in case there's any confusion, I haven't moved on to talking about pacemakers here. We're still talking about voice and speech analysis, but hopefully you can see that we did take some inspiration from that framework when coming up with this framework here. So we can elaborate on this further. Linguistic analysis focuses on specific words and language patterns used, while acoustic analysis looks at the variations in audible and non-audible sounds. And the subclassification of this can be pretty complicated, and it's beyond the scope of what I want to talk about today. But in general, linguistic features are probably a bit easier for us to intuitively understand because we're talking about the patterns of words and sentences. Acoustic features can probably be best understood when we transform sound into graphical form, and that allows us to visualize specific features. And without getting too nuanced about that, some basic acoustic features that we can look at on graphs include things like the number of vibrations, minimum frequency, frequency range, relative amplitude, as well as the width and depth of specific shapes like craters shown there. And so now I'll talk about the steps that are involved in developing a voice biomarker. We've talked about the types and techniques of voice recordings already. In addition to this, as we can see on the top right there, we need relevant clinical information to provide a set of labeled gold standards for the clinical outcomes that we're interested in. This then facilitates the training and testing of voice biomarkers. Next, audio recordings need to be pre-processed, and there's several different steps involved in this, including resampling, normalization, noise reduction, and so on. Then, in accordance with a framework that was advanced by the Digital Medicine Society, voice biomarkers need to undergo 3 critical steps. The first is verification, the second is analytical validation, and I talk about these 2 on this slide, and the third is clinical validation, which I talk about on the next slide. Briefly, verification looks at assessing the quality of speech recordings, while analytical validation checks the accuracy and reliability of speech sample processing. Next, we move on to feature extraction, with the term feature referring to the most dominating and discriminating characteristics of a voice signal that contribute to the training of machine learning algorithms. And as we talked about before, these can be acoustic features or linguistic features. Then, features need to be selected, and there's various statistical methods that we can use to do this. And these features are then used to train machine learning algorithms to classify clinical outcomes. These algorithms are then tested, and then I come back to the third step that was mentioned by the Digital Medicine Society, which is clinical validation. And this assesses how well a voice biomarker corresponds to clinical reference standards. And for this, we report performance metrics that we're all familiar with, things like specificity, sensitivity, and so on. And then last, additional steps are needed to ensure that voice biomarkers are safe and effective to be used in clinical practice, as outlined at the bottom there. And I'll talk about some of these steps a bit later in the presentation. So now we can consider what we've learned so far. Now we can look at what we've learned so far and consider some examples. In some of the studies that I've been involved in to date, in which we evaluated the relationship between cardiovascular disease and voice biomarkers, and I'll talk about some of those results shortly, we asked patients to perform 3 separate 30-second recordings. The first one was reading pre-specified text out loud. The second one was describing a positive emotional experience. And the third one was describing a negative emotional experience. So why did we choose an approach like that? In all honesty, when we first started this line of work, we didn't have a lot of preliminary data or previous studies to help inform our protocol. And if there was a link between cardiovascular disease and voice and speech, it wasn't obvious to us whether linguistic features or acoustic features would be most revealing. And so we created a protocol that cast a wide net, so to speak, trying to balance the various different methods that we had available to us. Spontaneous speaking tasks, for example, require minimal to no supervision, so they're easy to obtain. But acoustic signals vary more in spontaneous speech compared to a controlled task. So it wouldn't be a good approach if you're looking to extract acoustic features. But spontaneous speech are very good at eliciting changes in the organization of language. And so it's great if you're looking to draw out linguistic features. On the other hand, reading scripted text requires instruction and supervision, but provides more control over the task. And so it's better at reliably capturing important changes in acoustic features. And so taken together, this really calls for a selective approach. Linguistic features from spontaneous speech may be helpful when detecting disorders like depression and Alzheimer's disease, where we know that language content and flow may be most relevant. Whereas acoustic features, when asking individuals to perform tasks like sustained vowel phonations, may be useful when detecting things like Parkinson's disease, or when we ask individuals to actively cough or actively wheeze, may be useful when detecting things like pneumonia. Now, studies have shown that voice and speech biomarkers are associated with several disease states, including neurological, psychiatric, infectious, and even cardiovascular diseases. And now we'll go through some examples for each of these. We'll start with neurological diseases. Parkinson's disease is a neurodegenerative condition that's associated with well-characterized changes in voice and speech, including impaired phonation and impaired articulation. And so it follows that voice biomarkers may be useful to identify disease here. In this study, voice recordings were collected in individuals with and without Parkinson's disease and were used to train a machine learning model. And the authors were able to discriminate disease with the area under the curve shown in the slide here, even in individuals with little to no symptoms. And so it follows that this technique could allow for the detection of Parkinson's disease, even in its earlier stages, when changes in voice might otherwise be overlooked by patients and providers alike. Alzheimer's disease is another condition where voice analysis may be useful. And that's because we know that Alzheimer's disease, as well as other dementias, can affect spoken language in several ways, including verbal fluency and so on. And so it follows that a voice biomarker that looks at linguistic features might be most relevant here. In the first study on the slide, speech samples were obtained from individuals in whom Alzheimer's disease was diagnosed during lifetime and was confirmed at post-mortem. And the authors found subtle changes in language that were evident even during the prodromal stages of Alzheimer's disease. And in the next study, speech between patients with mild cognitive impairment and healthy age-matched controls was compared, and the authors demonstrated significant differences in features such as speech tempo, hesitation ratio, and so on. And so speech analysis may be able to discriminate pathological changes from normal age-related changes. Voice analysis has also been used to discriminate COVID-19. In this study that was published in 2021, recordings of voice signals into a smartphone were used to develop a biomarker in 80 subjects, 40 of whom tested positive for COVID-19. And the voice biomarker differed significantly between infected and non-infected individuals with an area under the curve of 72%. When the biomarker was combined with self-reported symptoms, the area under the curve improved to 85%. And now we also have psychiatric disorders. PTSD is a condition that we know its diagnosis typically relies on interview and self-report. And in this study, the investigators looked at speech samples that were obtained from veterans. Beginning with more than 40,000 speech features, the investigators ultimately fixed on 18 features, which collectively provided an area under the curve for the detection of PTSD of 95%. Now, there's other psychiatric disorders as well that have been evaluated. These include things like suicidal ideation that was correctly identified in war veterans with a high sensitivity. Depression severity has also been looked at. Depression response to pharmacotherapy has also been looked at. And lastly, acoustic and linguistic features have also been used to discriminate bipolar disorder. And so now we move on to cardiovascular disease. To my knowledge, this is the first study that evaluated the relationship between voice and cardiovascular disease, and it was published in 1990. This study included a small sample of healthy young and healthy elderly patients and an elderly group who had chronic atherosclerosis. They were asked to perform sustained vowel phonation exercises, and some of the features that they looked at included things like jitter, which is the cycle-to-cycle variation in voice frequency, and shimmer, which is the cycle-to-cycle variation in amplitude. And they found significant differences between groups in acoustic features, and these differences were most marked when comparing healthy young individuals to the elderly group that had atherosclerotic disease. Now, in the first study that I published in this area when I was at Mayo, we looked at the relationship between voice features and coronary artery disease. We recruited 101 patients who underwent clinically indicated coronary angiograms, both as inpatients and outpatients, as well as 37 controls who either underwent non-cardiac procedures or no procedures at all. It was a cross-sectional study, and the voice recording protocol that we used was the same one that I described earlier with the 3 separate 30-second recordings. We went on to identify 81 different acoustic features from each recording, and the outcome of interest was obstructive coronary artery disease. And as for the results, you can see the table on the right there. This represents multi-variable logistic regression analyses in which we identified 2 acoustic features that were independently associated with coronary disease, features 43 and 71. And here I break down the association according to the type of recording. Note that the second recording is the description of a positive experience, and the last recording is that of a negative experience. And we can see that both features were more strongly associated with coronary disease when patients were asked to describe emotionally significant experiences. Now, in the next study that we looked at, this was a prospective study. We looked at 108 patients who underwent coronary angiography at baseline. And this time we used a composite biomarker that comprised of more than 200 acoustic features in aggregate that was developed in a prior training cohort before being tested here. And like I said, this is a prospective study, and we followed patients across a median duration of 24 months with the aim of seeing if the voice biomarker at baseline might be able to predict incident coronary disease-related events at follow-up. The primary outcome of interest was the composite of presenting to the emergency department with chest pain, being admitted to hospital due to chest pain, or being diagnosed with an acute coronary syndrome, which were our acute outcomes. And our secondary outcome was the composite of a positive stress test or coronary disease at invasive angiography at follow-up, which were our chronic outcomes. Now, patients were separated into 3 tertiles according to the distribution of their voice biomarker values, T1, T2, and T3, and they were separated into 2 groups, a high voice biomarker group, T3, and a low voice biomarker group, T1 and T2, and then event rates were compared across groups. And here I show the Kaplan-Meier curves showing the composite primary outcome-free survival on the left and the composite secondary outcome-free survival on the right. And we can see that there were significant differences between groups for the primary outcome, but not for the secondary outcome. And here I show a table showing the association between the voice biomarkers and each of the composite outcomes. And we can see that there were significant associations between having a high voice biomarker value compared to a low voice biomarker value and the primary composite outcome in both univariable and multivariable analyses. Note that the multivariable analyses were adjusted for the degree of coronary disease identified at baseline coronary angiogram. And there was also a significant association between having a high voice biomarker value and the secondary composite outcome shown in the multivariable analysis. So now we'll move on to the disease category in cardiology in which voice and speech biomarkers have the strongest evidence, and that's heart failure and pulmonary hypertension. We know that heart failure affects more than 60 million people worldwide and is associated with significant morbidity, mortality, and high cost to healthcare systems. The graph on the left here shows that the United States bears the 3rd highest annual healthcare costs per heart failure patient per year worldwide, amounting to almost $20,000. Pulmonary hypertension, on the other hand, is prevalent in patients with heart failure. It's a marker of disease severity, and irrespective of a patient's ejection fraction, is associated with worse mortality. The graph on the right shows cumulative survival on the y-axis, time on the x-axis. Patients with pulmonary hypertension are in red and those without are in blue, and we can see that pulmonary hypertension is associated with worse survival. Now, heart failure is a progressive disorder, and more chronic and severe disease is associated with worse pulmonary hypertension. But we know that starting therapy in early heart failure is associated with better outcomes. In this randomized controlled trial that compared the ACE inhibitor enalapril against placebo in patients with early heart failure, enalapril was associated with lower rates of death or heart failure hospitalization. And so strategies that screen for heart failure and pulmonary hypertension early in their disease course would be of great value. And so how might we do that? We know that edema is a key feature of the heart failure syndrome, and even though it's associated with weight gain, that weight gain can often occur late and may not be identified in time to prevent decompensation. The graph here shows the cumulative percentage of patients experiencing symptoms prior to being hospitalized with an episode of acute heart failure on the y-axis, and on the x-axis we have the number of days prior to admission. And we can see that edema is an early feature of acute heart failure that affects more patients sooner than weight gain or any of the other presenting features for that matter. Now, of course, we know that edema can accumulate in the lungs, but it can also localize to the vocal folds and the vocal tract. And so it makes sense that a speech and voice biomarker may be relevant to patients with heart failure and pulmonary hypertension. Now, we previously looked at patients who underwent right heart catheterizations to evaluate pulmonary hypertension. This was a cross-sectional study, and we used the same composite biomarker that I talked about during our coronary disease prospective study. The primary outcome was pulmonary hypertension, And we showed that patients with pulmonary hypertension had significantly higher values of the voice biomarker compared to those without pulmonary hypertension. And we also showed in a multivariable analysis that the voice biomarker was associated with pulmonary hypertension in all patients and after stratification in patients with an elevated wedge pressure. In another study, we looked at more than 2,000 patients with congestive heart failure using the same composite biomarker, who we then followed across time for clinical outcomes. On the right here, I show two Kaplan-Meier curves. The top one shows findings related to cumulative survival, and the bottom one shows findings related to cumulative hospitalization rates. Patients were divided into 4 quartiles according to the value of their voice biomarker, shown on the graphs as blue being quartile 1, brown's quartile 2, green's quartile 3, and red's quartile 4. And we can see that there was a lower cumulative probability of survival and a higher cumulative probability of hospitalization with increasing voice biomarker values. And in multivariable analyses, high voice biomarker values were significantly associated with both mortality and hospitalization at follow-up. Other groups have also looked at the association between acute heart failure and speech. The first study on this slide included 10 participants, and using acoustic analysis showed that patients with acute heart failure exhibited changes in acoustic features such as fundamental frequency after compared to before being treated with diuretics. The next study here showed that glottal features, which are the features that come from your vocal folds, classified acute heart failure accurately. They also showed that MEL frequency sepstral coefficients, or MFCCs, were more accurate in discriminating heart failure. Now, MFCCs are very important acoustic features, and they're used a lot in commercial speech recognition softwares. They're used, for example, in Siri on your iPhone, as well as Alexa at home. And I'll touch on these again later in the presentation. And in the last study here, patients treated for acute heart failure showed faster speech rates and longer phrases after compared to before being treated with diuretics. Now, these studies included small sample sizes. They focused on acute heart failure only as opposed to chronic stable disease, and they didn't include an assessment of pulmonary hypertension, which, as we know, is relevant for prognosis. And so we wanted to perform our own larger analysis, which I'll outline in the coming slides, and they had the following aims. The first one was to determine the association between acoustic features derived from speech and chronic heart failure and pulmonary hypertension as separate conditions and in combination. And second, we wanted to train and test deep learning models derived from speech to discriminate heart failure and pulmonary hypertension from healthy controls. So acoustic analysis allows us to be hypothesis-driven in our investigation as we try to understand and explain what specific characteristics in voice and speech may be most relevant to heart failure and pulmonary hypertension. Deep learning models, on the other hand, aren't really hypothesis-driven per se. You just apply these sophisticated algorithms to speech and see what it makes of them. But they offer the greatest potential of performing this kind of research at scale. And so we wanted to evaluate both methodologies here. And so what were our methods for this study? We recorded speech samples in patients recruited from a variety of clinical settings, including outpatient clinics and the echo lab. And the exclusion criteria are shown on the slide there. Information was collected on demographics, clinical history, and echo results, and the diagnosis of heart failure and pulmonary hypertension were based on universally accepted definitions shown on the slide here. We then grouped and analyzed our patients into 4 categories, with those without either pulmonary hypertension or heart failure on the left, those with either just pulmonary hypertension or just heart failure shown in the middle 2 columns, and those with both diseases shown on the right. Now, speech samples were recorded in a quiet room using an iPad and involved reading the passage that I show in this slide out loud. All reasonable efforts were made to avoid background noise, and for the current study, we focused on sentence 2 for our analyses. Now, starting with acoustic analyses, we used the audio processing software PROT to analyze our files, and we focused on 3 specific acoustic features. The first was speaking rate, which is measured in syllables per second, and the next 2, we focused on something called the sepstral peak prominence, which is an important acoustic feature that correlates with the human perception of hoarseness. Now, we assess this first in voiced segments of speech and then in all speech. So what's the difference? Now, voiced speech refers to the sounds in speech that have their source in vocal fold vibrations. So in simple terms, that's basically referring to vowels, which we understand, and voiced consonants. So what's a voiced consonant? As an example, the sound D is considered to be voiced, while the sound T is not. And we know this because if you pronounce both sounds out loud with your hand on your throat, you'll be able to feel your vocal folds vibrate when you pronounce D, but not with T. Now we'll discuss the methods behind the deep learning segment, for which we looked at two different representations of speech. These were MEL spectrograms and MEL frequency cepstral coefficients, or MFCCs, which I mentioned earlier. And so what are these? This is going to involve taking a brief step back and looking at the basics of how we look at sound. So just bear with me for a few moments here. Sound can be presented with time on the x-axis as a waveform, which is the time domain, or frequency on the x-axis as spectrum, which is the frequency domain. In order to transition from the time domain to the frequency domain, we need to apply a mathematical transformation called the Fourier transformation. And this produces spectrum, which we can see on the right here. Now, spectra provide information on the frequency content of sound, but doesn't provide any timing information. So can't tell us the order in which those frequencies occur. Now, spectrograms can help with this by showing time on the x-axis, frequency on the y-axis, with darker shades of gray indicating higher amplitudes of sound. In order to transform from a spectra to a spectrogram, we need to produce multiple Fourier transformations at successive intervals across a waveform to produce multiple spectra that we then synthesize together to get us our spectrograms. Now, spectrograms are fine. They show frequency in a linear fashion, but humans don't perceive sound in a linear fashion. We perceive it in a logarithmic fashion. And this means that two frequencies that differ by a factor of 2 are perceived similarly. And for the musicians who are in the audience, this gives rise to the concept of octaves. And so how do we present sound in a perceptually relevant manner? We do this by applying a further logarithmic transformation to spectrograms to produce what we call a MEL spectrogram. And this is the result. Times on the x-axis, frequencies on the y-axis, and amplitude is shown in color. Now, MFCCs are just an alternative image representation of speech that are arrived at by applying further logarithmic and further Fourier transformations to MEL spectrograms. And they're especially useful because they separate out the sounds that come from the vocal folds, which are not very discriminating, from those that come from the vocal tract, which are more specific to individuals. And that's why MFCCs can be used for speech recognition, like in things like Siri. And so here's an example of an MFCC image. And so why did we bother going through all of this process? Well, machine and deep learning models undergo training from input data in order to then make predictions about data that's never been seen before. And deep learning models, which is what we're looking at for this study, in particular, look at something called neural networks, and they often take their input data in the form of an image. And so, as image representations of speech, it makes sense that we can use MEL spectrograms and MFCCs for this purpose. And so what were the results of this study? Between 2021 and 2024, 2,223 outpatients underwent speech recordings, of which 70 were excluded for a variety of different reasons, shown here on the slide, leaving us with 2,153 patients. The average age was 65 years and 58% were male. Almost half of all patients had neither disease, 15% had both diseases, and the remainder had either pulmonary hypertension only or heart failure only. This table summarizes the demographic characteristics across groups. Patients with pulmonary hypertension and heart failure combined were older, with an average age of 71 years. Proportion of female sex was highest in those with pulmonary hypertension only, and ethnicity didn't vary significantly across groups. This table summarizes the distribution of comorbidities across our groups, and we can see that rates of all of the comorbidities listed were generally highest in those with heart failure only or heart failure combined with pulmonary hypertension. And so what were the results of the acoustic analyses? This slide summarizes the results of linear regression analyses comparing the 3 acoustic features between patients with pulmonary hypertension only, heart failure only, and pulmonary hypertension and heart failure combined versus no disease On the left, we have the univariable analyses, and on the right, we have the multivariable analyses. And at the top, we can see that there were significant differences between patients with pulmonary hypertension only and those with no disease in sepstral peak prominence, both in voiced speech and in all speech. And at the bottom, we can see that there were significant differences in speech rate between patients with pulmonary hypertension only, heart failure only, and pulmonary hypertension and heart failure combined versus no disease, with the direction of that difference implying that patients with disease spoke more slowly. And what about our deep learning results? This slide shows the area under the curve for the classification of pulmonary hypertension only versus no disease across the various deep learning models that we trialed. And we can see that pulmonary hypertension was discriminated well, with areas under the curve in the 0.75 range. On this slide, we have the areas under the curve for the classification of heart failure only and heart failure combined with pulmonary hypertension versus no disease, wherein the accuracy was more modest, with areas under the curve in the 0.6 to 0.7 range. And so to summarize our results, sepstral peak prominence, which is a measure associated with the human perception of hoarseness, differed significantly between patients with pulmonary hypertension only and those without disease. And speech rate was slower in patients with both pulmonary hypertension and heart failure separately and in combination compared to patients without disease. Meanwhile, our deep learning models discriminated disease moderately well and performed best when discriminating pulmonary hypertension. And so what are the implications of these findings? Analysis of recorded speech using acoustic analyses or deep learning models could form part of a strategy to screen for heart failure and pulmonary hypertension in a non-invasive, convenient, and potentially cost-effective manner that could be carried out remotely. But of course, we're going to need further studies to show that this approach adds value to established measures and leads to improvements in patient outcomes as well as costs to healthcare systems. So now I'll just finish by summarizing some important future steps that will need to be considered for this field to evolve. First, there needs to be more standardization in voice sample collection protocols. It's likely that voice recordings will almost exclusively be performed outside of the lab setting in uncontrolled, everyday situations using a variety of different devices. And so standardization is going to be very important. This would then permit data sharing that could pave the way for large-scale voice sample repositories. That's going to be important for future research. We also need more clinical trials in large demographically and linguistically diverse populations. Next, it's worth highlighting that voice biomarkers really should be viewed as adjunctive tools which can aid but never replace healthcare providers. And this is very important to think about when we start contemplating how voice biomarkers might actually be integrated into clinical practice. Also, many patients of ours own smart devices, but how voice biomarkers might actually be used from home in a way that's safe for our patients still needs to be clarified. Also, voice biomarkers are going to raise a number of questions related to things like agency approval from the FDA, business models for companies that develop these biomarkers, as well as the willingness of insurance companies to provide coverage. Next, if we do start relying on home monitoring systems that include voice biomarkers to make our treatment decisions, this makes ensuring the reliability and validity of these voice biomarkers even more important. We should also start considering best practices for implementing remote care, as well as the unintended consequences of things like the so-called digital divide, wherein certain groups of patients, such as the elderly, may be less able to access remote care through lack of access to the internet or lack of technology literacy. And lastly, there's privacy concerns. Voice data is potentially sensitive, and so regulation and safeguarding sensitive data will be vital. And so now I'll just use this time as an opportunity to promote and encourage audience members to enroll in a study that we're conducting here at MHI, for which we were recently granted the Research Innovation Award at Alina. We're trying to determine if we can identify acoustic and linguistic signatures of burnout by inviting physicians, NPPAs, nurses, and other clinical staff to provide brief speech and voice recordings and to complete some surveys asking about wellness and burnout and so on. And as part of a secondary objective, we're planning to assess the efficacy of a novel stress management device called Carmigo, shown here, in individuals who have burnout. So if you're interested, please get in touch and we can provide some more information. And with that, I'll conclude. Thanks very much for your attention.
Thank you, Jessica. Excellent overview. And I'm sure there'll be some questions from the audience, unless everyone understood perfectly the specifics. But here's one question to get started. As you said, this can potentially be applied to anyone, anytime, right? Like Dragon, we use every day in the Epic is based on to some extent. So there are probably a lot of recordings already out there. And that might be beyond the scope, but is there a possibility of taking some of the existing recordings, whose classification might be an issue, and using them to analyze the characteristics for like burnout, for example, after we get the preliminary, to get a big sample already recorded into the clinical databases?
Yeah, in theory, it's certainly possible. The issue becomes, as you start doing more research in this, you start realizing that your collection protocol really matters. Background noise, distance from the microphone, what protocols and so forth, they really matter because it influences things like your acoustic signal, your pre-processing. There's a lot of technical features that I'm only myself beginning to learn about as well. So it's definitely possible, but I think we just have to acknowledge that there's going to be some uncleanness in that data that we just have to accept. But if we start doing this more mindfully and we have protocols that we put in place a priori, then we can start doing this in a cleaner, more reliable fashion. So it's a great idea, but I think we need to plan it rather than looking retrospectively. That's when we start finding more noise and less signal.
Thank you. Thank you. That was a fantastic talk. I really appreciated that you included the comorbidities in there. As we're looking at multiple comorbidities, or as we're looking at differences across social groups, how do you account for those subtle differences in speech as you're building these platforms?
It's one of the biggest concerns and limitations in this area of research. So put differently, are we actually picking up on the diseases per se, or are we picking up on an older, sicker, more frail, more comorbid phenotype? And quite honestly, we don't have the answer to that. We can perform our multivariable analyses and adjust for these variables, but I'm not sure if we're convincingly demonstrating that we're isolating heart failure per se or pulmonary hypertension per se. It's a big challenge. We don't have good solutions at the moment. I think a good strategy that a lot of people in this area are thinking about is pivoting away from population-based comparisons, so disease versus no disease, and thinking more about individual changes. So you become your own control and doing temporal analyses. So what's your voice like in January? What's it like in February? What's it like in the morning versus the evening? And I think that's a far more powerful tool. And it might not offer us the ability to screen for disease de novo, but it might allow us to assess progression of disease in individuals who already have it, or treatment response in individuals who are already on treatment. And that sort of accounts for other things like, do you have a cold, and do you have morning voice, and have you just had a hot beverage, and were you singing yesterday? So these are so many variables, so many variables, most of which we don't even account for. And so making population level differences clinically relevant is quite tough. Some people are trying to address this by just collecting huge samples and applying more and more sophisticated deep learning algorithms. And that's fine. It's potentially effective, but ultimately we want this to be used in clinical practice. And in order to get clinical buy-in, you need to have some explainability of what you're doing and what you're looking at. And I don't think we have that. And I think if we're just looking at 50,000 patients, abnormal, normal, it's less convincing. If you do these more thoughtful, small sample assessments where you look at mechanisms and you think about causal associations, it's a bit more persuasive. And I think you can probably convince a lot more people that you have something here, rather than just voodoo and hand-waving stuff. So I think intra-individual differences is probably the way to look at this.
Thank you for your that talk. Do you have any information on what happens with sleep deprivation in your voice, sort of a before and after?
I'm sure there's a link. I don't think I've seen any studies that look at sleep. Sleep apnea has been looked at. So I guess that correlates with sleep deprivation. But I haven't seen sleep deprivation per se. But it's definitely a worthwhile question for sure.
Wondering about the burnout association.
Sure. Yeah.
All right, any other questions? If not, just thanks again so much, and please feel free to contact us for the study.